And just to orient you a little bit, so this is Madison, Wisconsin, and it's one of just a couple of cities that is built on an isthmus. So here's the capital. That's Lake Monona and Lake Mendota. I know on the coast you don't know much about the Midwest, so sometimes I'll tell people that this is the Atlantic Ocean and that's the Pacific Ocean, but you're much too sophisticated for that. And I'll just point out, so this is, the university goes about 3 miles along the lakeshore. This is University Land here, Picnic Point, beautiful place for a walk. The medical center is back in here. And Dr. Steen grew up just a little bit off to the right here in Shorewood. And we're very lucky to have him visit us each year and give a talk to the Department of Pediatrics. I'm going to give you my disclosure slide, but I'll start by saying this lake is frozen 4 months out of the year. And the second thing is we love it that way. So, but I do consulting work looking for anti-rhinovirus medications with a number of companies. Nothing successful yet, so I don't think there'll be any problems with conflicts during the talk here. So I'm going to start with a case report, and one that's very familiar, and it's not a diagnostic dilemma. It's an 8-year-old boy with a history of moderate persistent asthma who developed URI symptoms 3 days ago and then started wheezing. Albuterol gave incomplete relief during the day, and it was even worse at night with all-night coughing. He went to the emergency department at 3 in the morning and had low O2 saturation, was admitted for an acute exacerbation. He had a history of 3 previous hospitalizations, all preceded by colds. And when he goes back to school, it's particularly bad for him. He misses 1 to 2 weeks of school per year, and he's got multiple allergies, including pets, grass pollen, alternaria, and grandmother has a cat, and he spent some time with grandmother before this episode, in addition to getting a cold. Spotty adherence to medications like virtually all asthmatics, and then on examination, nasal congestion and rhinorrhea, shortness of breath, expiratory wheezing. So it's very clear what's going on here. This is an exacerbation of asthma precipitated by a cold, and in 8-year-old kids, most exacerbations are precipitated by colds. So what I'd like to do today is really go over the epidemiology and natural history, some of the virology, and touch on pathogenesis and some interesting advances in treatment. There may actually be some things we can do about this in the near future. So in terms of the epidemiology, most asthma exacerbations in school-age children are related to viral infection. In the fall, you see the strongest relationship where it's probably 80 to 90%. And in adults, you still see this relationship. It's not quite as strong, but probably half of exacerbations in adults are related to a recent cold. And rhinoviruses are most commonly detected. There can be other viruses as well, and age makes a big difference here. Infants have the biggest problem with these episodes, and then children, and then adolescents and adults. And there's a very strong relationship with allergy. Highly allergic individuals are quite likely to develop virus-induced wheezing episodes, and we'll talk about some of those potential mechanisms. And there's really some very striking data coming from Canada with a single health payer. You can get some tremendous epidemiologic studies. And what they've demonstrated is that when kids go back to school, and their school nationwide is tied to Labor Day, so when they go back to school, there's a very striking peak in asthma exacerbations and in common colds during the spring and fall. So here's the study from Neil Johnson and Malcolm Sears, Canadian hospitalization admission data, looking at the timing and magnitude of peaks in hospitalization. And every year, there's a striking peak. 17 days after kids go back to school, you see this big peak in school-age kids. Preschoolers are a little bit later, and adults are a little bit later than that. And everyone here knows that actually common colds don't transmit very well in between adults, but if you have a 2-year-old with a common cold, you will get a common cold. So it's that up close and personal and prolonged contact that really leads to spread. And here are the data. So these are, it's normalized to the annual rate, but then it's plotted by month. This is 16 years worth of data right here, and you can see every fall there's this tremendous spike in asthma hospitalization rates in Canada. And you can see a smaller spike when kids go back after spring break. And this epidemiology, these patterns are very consistent among temperate areas around the world. So what about risk factors for asthma exacerbations? And this is a study that was done among inner city children who had moderate to severe asthma. This is part of the Inner City Asthma Consortium led by Bill Bussey at the University of Wisconsin. 400 subjects who were in the control arm of 2 treatment studies. One called the ACE study that looked at as needed versus scheduled treatment, and one, the ICATA study, which is an Omalizumab study. But they used the placebo groups in both of these studies. So they had standard asthma care, inhaled steroid, and so forth. The kids were aged 6 through 20 years, and the asthma treatment was directed by guidelines, national guidelines, and with very close monitoring. So very close adherence as well. And this is even with very good asthma treatment, a very detailed asthma treatment plan based on guidelines. You see this spike up, this increase in asthma exacerbations, and these were defined as requiring systemic steroid treatment in the spring, lower in the summer, and then a big peak in the fall. And really, in these inner city studies, we've seen this pattern over and over again. So the question is, what are the risk factors for exacerbations? Particularly, what are the risk factors for having these wheezing episodes in the fall? So here are the rates of exacerbations if you just plot these. So 28, almost 30% happen in the fall. It's about twice as likely in the fall than in other seasons to have an exacerbation of asthma, a little bit of a bump in the spring as well. So these kids had quite a bit of data at baseline. And so you can see, the demographic data, total IgE, blood eosinophils, symptoms, very detailed lung function, number of exacerbations previously, and so forth. So each of these things was evaluated. What predicted the kids who were likely to develop exacerbations in the fall versus other times of the year? And so these are the 4 seasons. Again, this is just the variance explained by the predictors that we're going to be talking about. So 30% of the variance in the fall we could explain with this analysis. And interestingly, it was exacerbation history. Of course, we know this. The most likely time to have an exacerbation is right after you had the previous exacerbation. And also allergy. But the interesting thing about these fall exacerbations, and this has been found in a number of studies now, it's not the fall allergens, ragweed and alternaria. It's perennial allergies that set these kids up for fall exacerbations. So how perennial allergen exposure, the year-round stuff, in the inner city it's cockroach, dust mite, and mouse. In other places there can be other allergens. How that sets you up for a fall exacerbation is an interesting question. Other times of the year, it was exacerbation history or treatment level, which is asthma severity, and then lung function. Low lung function, you're certainly at risk for more significant things. But this really underlines that there's something going on between allergic inflammation and allergy and viral infections to cause these exacerbations. So let's talk a little bit about what's known about how rhinoviruses cause exacerbations of asthma. And the first thing I want to show you are data that indicate that we always think about the common cold as an upper respiratory disease. Well, it's not. It's really an upper and a lower respiratory tract infection for many individuals. So what happens is the virus certainly inoculates the upper airways. The most efficient way to inoculate someone is either through the conjunctiva or the nose, not orally. Then you get spread to the lower airways. You get lower airway inflammatory processes and some interactions with allergy and eosinophilia that really predispose to more significant illness. So what's the data on that? Well, first of all, common cold viruses were first found in the mid-50s in the common cold unit, and Dr. Cherry was telling me earlier that he'd spent some time in the common cold unit. This was a converted bunker in the UK, that the American government gave to the UK, and they set up this common cold laboratory where they tried to find out what were these viruses. Influenza was known at the time. What were these other viruses that caused respiratory illnesses? Well, their studies led to the finding that you could grow most rhinoviruses best at 33 to 35 degrees centigrade, cooler, than core temperature. And so that was thought to limit the extent of the infection to the lower airway. But a guy named Regis McFadden did some really interesting studies. He was looking at exercise-induced asthma where airway cooling is a factor, but breathing room air at rest. These were the temperatures that he found using bronchoscopy and a very small thermistor. So the upper airway is at the perfect temperature for rhinovirus growth. When you get down to the carina, 33 to 34, you don't exceed 35 degrees until you get to fourth generation bronchi. So actually the large and medium airways in the chest are at the perfect temperature for rhinovirus growth. Of course, the lung parenchyma is at 37, and this will inhibit some, but not all, rhinoviruses. And in fact, we've done studies where we've inoculated people in the nose and waited a few days and then did lower airway biopsy and stained for rhinoviruses. And this is a monoclonal antibody for rhinovirus 16. You can see the very characteristic cytoplasmic staining. The epithelium looks a little rough. This is a patchy infection, so you see small patches like this. But about half of the people, and these are normal individuals or people with asthma, about half the people will get significant virus in the lower airway after upper airway inoculation. And you can quantitate this virus. So that's a few spots on the slide. What we did was to take nasal lavage cells from nasal washes and with qPCR measure how much virus was being shed and do the same thing with sputum. And it's about half of the people who shed in the lower airway. So you can see the error bars are quite wide. But we have a number of individuals where the sputum amount of virus in the sputum exceeds that in the nose. And also the kinetics are a little bit different. It's a little hard to see with this group data here, but you see the peak between 2 to 4 days for rhinovirus in the upper airway, whereas people in the lower airway, the virus can peak at 3 days or at 7 days. So sometimes it peaks a little bit later than the peak in the upper airway. So rhinoviruses are commonly involving the lower airway. In people with asthma, this has huge clinical consequences. And this slide looks like it exploded. But what I'm trying to show here is virus-infected epithelium. We know that the virus can grow in patches in the lower airway, and the epithelium really directs the subsequent events. So mediators from the epithelium cause plasma leakage. This is incompletely understood right now. Mucus hypersecretion, which contributes to the airway obstruction. Airway hyperresponsiveness, which is one of the key features of asthma, gets worse during a cold. Neural activation, these nerves look like they've wilted here, but this certainly is involved in the cough that occurs, plus neuroinflammation. And then chemokines that bring dendritic cells, neutrophils, and lymphocytes into the airway. And this combination, we think, is what really leads to the net effect of obstructing the airways and causing wheezing. But every infection with rhinovirus begins somewhere. It begins with a single cell or a single group of cells being infected. And so we're looking now, and a number of other groups as well, when you get that first infected cell, so the virus gets into the cell and then it breaks and then it spreads other viruses, and then you start to see tissues infected, and finally it gets to the point where the patient is infected. We know this process in individuals from inoculation studies. It's about 48 hours between when you inoculate someone and the symptoms really grow into a cold. There's some minor symptoms that happen earlier. And so, the focus, what determines whether a rhinovirus causes an asymptomatic illness or a lower respiratory illness probably starts very early. Those early events can really lead to this infection being very mild or more significant. So what are these early events that determine the course of viral infections? And we'll divide these up into those that involve the virus and the virulence of the individual viruses versus the epithelium. We think of the epithelium as a barrier in the lower respiratory tract, and there's been a lot written about the physical barrier property of the epithelium, and the mucus layer, but it's also an immunologic barrier. It has antiviral responses. It has antibacterial mechanisms that can be breached. So we'll talk first about viral factors. And rhinoviruses, again, were found first in 1956. Some people say 1953, but somewhere in the 50s. They've been known for 50 years, the A and the B viruses, and we always thought there were about 100 of these. And the big surprise was in 2006, people started finding the C viruses. These viruses have been around all along, but they were not detectable because they don't grow in standard tissue culture at all. And it turns out that the reason is that they have a different receptor. It turns out that these viruses are very closely associated with wheezing episodes and asthma. But there's 78 A's, 30 B's, and 51 C's. With 160 rhinoviruses, you might imagine that there might be some viruses that are more virulent and some that are less virulent. And in fact, case control studies that have looked at kids who are hospitalized with lower respiratory illnesses due to either asthma or with very young children, bronchiolitis, have found an overrepresentation of C viruses and in some cases A viruses. This is one from, this one down here is one from the CDC in the United States in hospitalized children compared to community viruses. And really, there was only one study that's ever shown a role for B, and subsequent studies suggest that this virus is really quite attenuated. So the C's and the A's are more linked to lower respiratory disease. We wanted to look at this in an outpatient setting. These were all case control studies. So we did a prospective study called Rhinogen, 309 kids, 166 with asthma. It was a very open door study. Pretty much every child was eligible unless they had chronic sinus disease or other chronic medical problems. And we did weekly nasal mucus samples during September and April, the two peak common cold seasons. We used PCR, multiplex PCR, to detect all common respiratory viruses. And for rhinoviruses, we did partial sequencing so we knew what species and what type. We had the kids keep very simple diaries. It just had different color stickers for none, mild, moderate, severe, for asthma symptoms, for those who had asthma, and for cold symptoms as well. And then we defined asthma exacerbations on the basis of lung function, so peak flow, as well as moderate symptoms and albuterol use. And this was the low-tech method that the kids really like to do. This is the nasal blow technique. And so you take nasal saline spray, put a spritz in each nostril, you have them blow their nose into a plastic bag, you put a little viral transport medium in and freeze it. The kids love to tell you what's in the bag, and they can play with it a little bit before we get it in the container there. And it's a really good sample for analysis by PCR. And this is what we found. So during the weeks when kids had no viruses, there were some baseline symptoms here. Keep in mind, half of these kids had asthma, and a number of these kids had allergies as well. This is September and April in Wisconsin. But the weeks where you had an A virus or a C virus, you had significant cold symptoms here. This was from their diaries. You had significant symptoms with B as well. It's just that they weren't very severe. When we looked at the asthma exacerbations, the risk of asthma exacerbation here, about 10% if you had no virus. Clearly there are other things that can cause asthma symptoms besides viruses, but about a 60 or 70% increase when you had an A or a C virus, and no increase at all with the B viruses. These really do seem to be attenuated viruses that don't cause lower airway symptoms. Well, there's been a lot of interest in interactions between viruses and bacteria going back many years. Clinical evidence showing that most cases of otitis media and sinusitis can be preceded by viral infection. Pneumococcal pneumonia is often preceded by a viral infection. So we wanted to see in the airway whether there might be interactions with viruses and bacteria that contribute to common colds or exacerbations of asthma. Mechanisms have been described, and one that was described years ago was that viruses can induce cell surface receptors that promote bacterial invasion. There are a number of other mechanisms that have been studied. So we hypothesized that rhinovirus bacterial interactions might contribute to severity of cold and exacerbations of asthma. This is some data from Hans Biscard. This is a birth cohort study, over 300 children. They looked in infancy. And the sample design was such that they had samples periodically in well children as these kids were growing up, and they also had samples during acute wheezing episodes. And like every other study, this group found that detection of a virus was associated with an increased risk of wheezing illnesses. And this is no surprise, but when you look at detection of bacteria, and here it was Moraxella, H. flu, and strep pneumo, you saw really the same odds ratio. So you were more likely to find these, and they did nasopharyngeal cultures here, these bacteria during wheezing episodes than when children weren't wheezing. So we went back to the Rhinogen study. We had 1,400 samples, and we extracted DNA to do PCR for 3 bacteria, the usual suspects here, in addition to the viruses. And one of the things that we found was that, again, these were weekly samples, whether the kids were sick or well, if we found this order effect. So virus generally preceded the detection of bacteria. I'm showing the data for strep pneumonia. The data for Moraxella and H. flu looked exactly like this. So if the week before there was no virus, you had a low rate of detection of strep pneumonia, and quantitatively, relatively little. If the week before you did have a rhinovirus, then the amount of strep pneumonia, first of all, the frequency of detection was increased, and the amount of bacteria were increased as well, suggesting that people who are colonized with strep pneumo, if you get a viral infection, it's a stimulus that can lead to proliferation of the bacteria. So does this have any clinical significance? So to do that, we calculated odds ratios that looked at combined infections versus single, you can call them infections or detections, whatever, with respect to illness, so any respiratory illness, and specifically exacerbations of asthma. So in kids who had Moraxella detected versus no pathogen, there was no increased risk for illness. If you had rhinovirus alone, the risk for illness went up, but not by a lot. But kids who had the combination of rhinovirus plus Moraxella, compared to those with no pathogen, had a greater chance, the greatest chance for illness. And those, if you compare, instead of to no pathogen, if you compare rhinovirus and Moraxella to rhinovirus alone, again, a tendency for greater illness if you have both organisms detected versus just one. And you see the same sort of relationships for strep pneumo. This is looking with respect to asthma exacerbations, so virus alone, a fairly low risk, and the highest risk is if you have the pathogens together, so the virus plus the bacteria. So this suggests the possibility that viral bacterial interactions do contribute to illness severity. This is still a hypothesis because we haven't done any interventional studies, and it's problematic thinking what those would be. But if you have a rhinovirus infection alone without bacteria, you have a fairly mild illness, and exacerbation is unlikely. If you have an A or a C species virus, and actually these were associated with bacterial proliferation more than the Bs were, or if you have co-infection or co-detection of a bacterial pathogen, then we see more severe illness, and perhaps exacerbations are more likely. So we're working on some follow-up studies to this at present. So anyway, I think one of the implications is that for efforts to treat virus-induced exacerbations or rhinovirus disease in general, that the A and the C viruses are the ones that you really need to go after, and Bs play relatively a small role. Since there's 160 viruses, it does help to be able to take out some of these. Bs are about 30 types. So next, we've talked about viral factors. Now let's talk a little bit about cellular factors. And again, the airway epithelium has a barrier function, and there's a physical barrier here. So if you take undifferentiated airway epithelial cells and you culture them for about 2 weeks, you can start to see tight junctions form. This is trans-epithelial resistance here, and you stay with this nice tight barrier. You start to see cilia develop, and this nice differentiated layer here with goblet cells secreting mucus and ciliated cells and so forth. And actually these cell layers, you can grow rhinoviruses in them, but they don't grow all that well. And so the concept is that perhaps if you disturb the epithelial integrity, then you're going to have more significant rhinovirus infection. So an intact epithelium, relatively low replication, mild or no illness, perhaps asthma exacerbation is unlikely. But if this is damaged, and you might think of inflammation in the airway as causing this damage, so allergic inflammation, pollutants, could be other things, then you may have greater replication, more severe illness, and an exacerbation might be more likely. So we modeled this in the laboratory. This says impressed, that's an old slide. It was actually published then. And what we found was that damaged epithelium did have enhanced rhinovirus replication. So we had intact epithelium. We treated it 3 different ways. This was all from the same donors. We increased the permeability by taking the calcium out of the medium. We stripped off the top layer of cells enzymatically, or we just scratched it and damaged the epithelium. And this is viral yield. So this is quantitative measure of rhinovirus 24 hours after inoculation. The cells were inoculated, washed, and then we waited 24 hours. The intact epithelium, relatively low amount of virus. If you increase the permeability or scratch the surface, you saw a modest enhancement in rhinovirus replication. But if you strip that top layer off, then you really saw a great effect on replication. And then what about the immunologic properties of the epithelium? How does that relate to severity of illness? Well, there's a lot of interest in the microbiome. I showed you some data on bacteria. There's a lot of studies going on how that affects epithelial cell biology. But we know that epithelium can make type 1 interferon and type 3 interferon, so interferon beta and lambda, and these have antiviral properties. A brisk upregulation of interferon really helps to limit the extent of rhinovirus infection. And then, of course, the epithelium includes other cells as well, so dendritic cells that make a lot of interferons, T cells and B cells are responsible for immunologic memory, and then effector cells, including macrophages, NK cells. And you have a coordinate response to a viral infection that can be very effective at limiting spread of the virus. Well, if you throw allergy into the equation, you've got other cells in the airway, and these cells make different cytokines. So with allergy, it's known that you get overproduction of cytokines such as IL-33, IL-25, and TSLP. These affect dendritic cells and also innate lymphoid cells in the airway and promote the secretion of type 2 inflammation, IL-4, IL-5, and IL-13. Then you have T cells differentiating into Th2 cells that draw eosinophils into the airway. And this actually can lead to a reduction in the fitness of this epithelium with respect to antiviral responses. So we wanted to model in the laboratory, does treatment of allergic inflammation reduce the severity of viral illnesses? And by extent, here in tissue culture, we're talking about viral replication. So you can neutralize some of the effects of allergy with Omalizumab. This is a monoclonal antibody that keeps IgE from binding to the surface of cells. And why would this hypothesis be tenable? Well, dendritic cells, which I showed a picture of earlier, are very important cells in the immune response to viral infections. These cells really make much more interferon per cell than any other cell in the airway. And when they're activated, these cells really, this is how they got the name dendritic cells. They put all these processes out, and depending on the type of dendritic cell, they can secrete interferon or they can serve as antigen-presenting cells and go to regional lymph nodes. Well, it turns out that these dendritic cells, like mast cells and basophils and even monocytes, express a high affinity receptor for IgE on their surface. So Fc epsilon R1. They can bind IgE on the surface of the cell. Normally, what you see if you incubate monocytes and dendritic cells with a virus is you see type 1 and type 3 interferon production. If you cross-link the IgE, and this is what allergen does, of course, what you see is a great reduction in the amount of type 1 and type 3 interferon production. So allergic inflammation that's IgE mediated can downregulate interferon, and this is demonstration of that in the laboratory. So here is rhinovirus-induced interferon lambda. If you put in an isotype control antibody, there's no effect. If you put in an antibody to cross-link IgE receptors, you see about an 80% reduction in type 1 interferon. So we'll come back to this later on, but it's at least one mechanism, and there have been others as well that may explain the contribution of allergy to a reduction in antiviral responses. So, and these findings, I think, have some treatment implications. So, we talked about viral infections in terms of epidemiology as being very closely linked to the risk for exacerbations of asthma. But it turns out that, most exacerbations, it's not just a viral infection. It's a viral infection in an allergic kid who's been exposed to tobacco smoke, and they may have the wrong bacteria in the airway. I mean, most of these things are very likely to be multifactorial. And, while we're struggling to come up with anti-rhinovirus medications, perhaps treatment of, allergic inflammation or, strategies that are aimed at environmental controls or even vaccination, may have effects on the morbidity due to viral infections. And what other factors? Nutrition, lifestyle, there's a lot out there to consider. So we'll kind of move into treatment, and I love to go on the internet periodically and look at cures for the common cold. Okay, you can learn a lot from the internet, as you guys know. So this is actually a very old, so Ptolemy, one of the ancient Greek physicians, thought that kissing the muzzle of a rat was a good cure for the common cold. And things haven't gotten a lot better since then, folks. So vitamin C has been looked at. It really has no effect. Echinacea, still, I don't know how many, $500 million. It's an incredible market. It's been absolutely definitively shown to have no effect on the common cold, but it still sells a lot. And of course, if you go to any drugstore, you'll find a plethora of common cold medications. And the reason there's so many is because none of them really work. And in fact, the FDA recommends against using them in children because no benefit and the potential of side effects. Zicam, this was one of my personal favorites. It does nothing to viral replication. It's a homeopathic remedy, but it does have a lot of zinc in it. Zinc was kind of in vogue. Unfortunately, it causes anosmia, so you won't get, it doesn't affect colds, but it does affect your sense of smell. And this was one of my favorite internet cures. So this guy poured 105-degree baths, kind of on the theme that, warmer temperatures inhibit rhinovirus growth, and he takes 305-degree baths a day, which is not a water-efficient strategy for Southern California. So. See, chicken soup does have some evidence base, so chicken soup does help people feel better. I don't think they did a placebo control here. I can't imagine what that would have been, but at least some data on that. And of course, there have been a number of rhinovirus antivirals. Capsid binding agents, these bind to a certain place on the surface of the protein capsid so that they can't bind to cells or can't uncoat. Pleconazole almost made it to market. In retrospect, it has no efficacy against rhinovirus C, which was not known at the time. This was killed because although it lowered common cold symptoms by about a day and reduced severity, it reduced the effectiveness of birth control pills. Probably not a great trade-off there. Vipendavir is a biota drug being looked at now in phase 2. There were protease inhibitors that worked, but were not felt to work well enough to market. And then other potential targets are being looked at now, including receptors and interferons. There's renewed, this floors me, but there's still renewed enthusiasm about a rhinovirus vaccine. I think this is based on the fact that now, there have been some advances in influenza vaccines that might be have some efficacy here, but there's 160 types of rhinoviruses. Some evidence for cross-reactive antibodies. They don't have a lot of neutralizing potential, but there are a number of companies that are looking to see if they can use new B-cell technology to develop cross-reactive antibodies. And then, treatment of cofactors. So, pathogens like strep pneuma and Moraxella, certainly not recommending more antibiotics for common cold. There's enough of that already, but maybe vaccine strategies here to investigate the possibility that they're contributing to common cold symptoms. A lot going on with the microbiome. Talk about that a little bit this afternoon. And then allergic inflammation in asthma. So we know topical corticosteroids treat allergic inflammation. Is that effective against colds? And the interesting data, I think, about Omalizumab. And then finally, boosting local immunity. Can you give interferon and see increased resistance against colds? So I'll show you some data with Omalizumab. This is from the Intercity Asthma Consortium. This was a study of moderate to severe asthma, and overall Omalizumab led to a 25% reduction in symptoms, 30% reduction in exacerbations. Very interesting, though, when you look at the pattern of exacerbations. This was the placebo group, which was guidelines-based asthma care. You see the spring and fall peaks. Here's the Omalizumab group. That peak in the fall really went away. And we had virology here, so we have data showing that narrowly treating Omalizumab, which narrowly focuses on IgE, did help to reduce virus-induced exacerbations, which is quite interesting. And we had a follow-up study to see, Omalizumab is quite expensive. We wanted to see whether treatment in the summer months would prepare and kids for school and reduce the rate of fall exacerbations. So it was a double-blinded study, placebo-controlled, with 513 kids who got standard care, Omalizumab, or higher doses of inhaled steroid. This was started just before school started, and we did weekly virology on these 500 kids for 13 weeks. We had over 6,000 specimens that were analyzed for rhinoviruses. And here's what we found. This was their historic data, the exacerbations in the spring, and you can see the expected peak. The placebo group, keep in mind this was guidelines-based therapy, very carefully orchestrated with the kids. So they had probably a lower peak than you would expect in the fall, but it was still there and really prevented by Omalizumab. But what was really interesting here is we did some mechanistic studies. Remember, I told you before that dendritic cells, which are type 1 interferon-producing cells, have lots of, can express high-affinity receptors for IgE. In allergic individuals, they express more of these receptors, and when they're cross-linked, you see a reduction in type 1 interferon and increased viral replication in the laboratory. We thought Omalizumab, by reducing the number of receptors and IgE occupancy, might boost type 1 interferon. And in a subset of kids, we drew blood and looked at dendritic cell function before and after treatment with Omalizumab. And here's what we found. So pre-treatment, the kids on the placebo and Omalizumab group had similar numbers of high-affinity IgE receptors on their dendritic cells. Post-treatment, as expected, this went way down in the Omalizumab group. And interestingly, when we incubated these cells with virus while cross-linking the IgE receptors, pre-treatment, the two groups were the same. Post-treatment, no change in the placebo group, but the kids getting Omalizumab actually had better type 1 interferon production. So neutralizing effects of IgE here led to better interferon production. And if you looked at the kids, this is just looking at that increase in interferon. So those kids who had a high increase in interferon versus a low increase in interferon were very unlikely to develop an asthma exacerbation. So linking this effect on interferon to reduce risk for exacerbation. And I'll just finish here with one study that I think is quite interesting. This was published last year in the American Thoracic Society journal, looking at inhaled interferon beta on worsening of asthma symptoms caused by viral infection. 147 adults with persistent asthma who were prone to exacerbations with colds. They were treated with inhaled corticosteroid, and they were randomized to getting inhaled interferon beta or placebo within 24 hours of onset of cold symptoms. Then they used a validated questionnaire to look at symptoms. They looked at a change in lung function, peak expiratory flow, and then evidence of immune activation, which I won't show you, but the interferon did cause immune activation. And here are the results. So in the intent to treat population, so everyone that they enrolled in the trial, there was no clinically significant change in symptoms. There were trends for reduction in peak flow. So this is the, for a better peak flow. So this is the placebo group and the treatment group showing a slight increase in peak flow. And viral shedding was a little bit lower. But I think what people are kind of excited about is if you looked at the individuals with the worst asthma, so you can grade asthma based on treatment level, so the ones who needed the most treatment to control them, they actually had a significant change in asthma symptoms and a much better increase in peak flow. So this suggests the possibility that inhaled interferon beta could be an effective treatment for individuals with severe asthma who are prone to exacerbations. So there's a long way to go with this. These were adults. This was a subset of a study, but they're doing another study now to see if this can be reproduced. So in closing, we've talked about viral factors and epithelial factors that contribute to the relationship between rhinovirus infections and asthma exacerbations. The viral factors include species, so the C and the A viruses are most closely associated with exacerbations, particularly the C virus, which is associated with more severe exacerbations and hospitalizations. We didn't talk about this, but the viruses have the different receptors, and it's interesting that the receptor for C virus is actually a tight junction protein on the surface of the epithelial cell. And also some data, suggesting that bacteria are increased in individuals who have more severe illnesses. And I think the question is this playing a causative role, or is this some sort of an epiphenomenon? And then the epithelial barrier, thinking of both it as a physical barrier, and we want to maximize its potential here, and also as an immunologic barrier that can be compromised in both cases by allergy, either allergic inflammation, leading to reduction in physical barrier, or downregulation of type 1 and type 3 interferon. Interesting that with an intervention study now, we're finding that there are fewer virus-induced exacerbations with Omalizumab, with a potential mechanism for this. And the possibility that individuals who do have low interferon production in the airway might benefit in the future from this therapeutic approach. So with that, I'd like to close. I'd like to acknowledge my funding from the NIH, NIAID for the inner-city studies, and the Rhinogen study, NHLBI for birth cohort studies. I have good friends at the Institute of Molecular Virology, led by Ann Palmenberg, who really are doing a great job with the molecular virology of C viruses. The Inter-City Asthma Consortium, led by Bill Bussey, and then a really group of great colleagues at University of Wisconsin, including Yuri Bochkov, who really leads our virology core laboratory, and Rob Lemansky and Dan Jackson in the COAST study. So thanks very much for your attention.